I'd like to talk about imaging of pelvic pain in the pre- and postmenopausal woman. Pelvic pain is one of the most frequent causes of outpatient visits. 25% of all referrals to gynecologists, 40% of all gynecological laparoscopic surgeries, and 12% of hysterectomies are due to pelvic pain. The medical care cost is more than $2 billion per year to treat pelvic pain. Pelvic pain is the most frequently caused by ovarian cysts, endometriosis, and pelvic adhesions. The initial imaging modality after a good history and physical is pelvic ultrasound. A good history should be obtained, the menstruating status, the type of pain, if it's severe, the location of the pain, if it's unilateral versus bilateral, the character of the pain, if it's intermittent, crampy, unconstant, should be documented. The onset of pain, the duration of pain is important. Past history of similar episodes and of previous surgeries is also important information. Associated gastrointestinal and gastrourinary symptoms should be obtained. A good physical exam should be done. Size and consistency and mobility of the uterus and ovaries should be documented. The type of pain during examination. Laboratory assays that may be done in patients who present with pelvic pain are complete blood cell count, erythrocyte sedimentation rate, vaginal swabs for chlamydia and gonorrhea, urinary analysis with culture, and in the menstruating female, pregnancy test with a beta human chorionic gonadotropin should be considered. Also, possibly a CA-125. However, the initial imaging study should always be an ultrasound. Acute pelvic pain is abrupt in onset and duration, measured in hours or days, rarely lasts more than a month without a crisis, resolution, or cure. It's due to direct insult of tissue trauma that activates the neuroreceptors and neural pain fibers. The severity of the pain is directly proportional to the severity of the traumatic insult. It's thought to be a symptom, whereas chronic pain is viewed as a disease. Chronic pelvic pain presents in the same location for at least 6 months. It may lead to years of disability, suffering, many medical procedures. It's associated with depression, and usually the patient is uncooperative and non-compliant. The differential diagnosis for chronic pelvic pain include adhesions, endometriosis, adenomyosis, infections, and neoplasms, which have uncertain relationship to the chronic pain. Chronic pain is probably multifactorial, therefore it is difficult to diagnose and to treat. Laparoscopy is a valuable tool in patients with chronic pain. It's performed in less than 50% of women and will confirm the clinical impression, establish a diagnosis, and it's also useful for therapy for removal of adhesions, aspiration of ovarian cysts, biopsy of intraperitoneal structures, avoiding exploratory laparotomy, and also can be very helpful for a follow-up course of the disease. Acute pain can be divided as its origin from gynecologic origin or non-gynecologic origin. Gynecologic causes of acute pelvic pain may be ovarian, such as cysts, functional or hemorrhagic, endometriosis, pelvic inflammatory disease, torsion, neoplasm, malignant or benign, including dermoids, cystadenomas, and fibromas. Gynecological causes arising from the uterus most commonly are due to fibroids, degenerative or torsion of a fibroid, or from adenomyosis, cervical stenosis. Extra-ovarian causes of acute pelvic pain include ectopic pregnancy, para-ovarian cysts, hydro or pilosalpinx. Non-gynecological causes of acute pelvic pain may be from gastrointestinal origin, such as appendicitis, diverticulitis, or inflammatory bowel disease. Urological causes include acute cystitis, ureteral and urethral calculi. Chronic pain can also be due to gynecological and non-gynecological causes. The most common gynecological causes of chronic pelvic pain include adenomyosis and endometriosis, adhesions, chronic pelvic pain, chronic pelvic inflammatory disease, pelvic floor myalgia, pelvic congestion, pelvic relaxation, retained ovarian syndrome, and uterine fibroids. The non-gynecologic causes of chronic pelvic pain may be due to abdominal wall factors, gastrointestinal origin, urologic, psychologic, neurogenic, or orthopedic in origin. A large amount of patients will present for pelvic pain. A large amount of patients that present for pelvic pain have a normal ultrasound. The outcome of these patients with pelvic pain in a normal transvaginal ultrasound is a high negative predictive value of 92%. In a study by Harris and his group evaluating 86 women, 77% of the pelvic pain improved or resolved in these women. The majority of these women, 86%, had acute or subacute pain, and approximately 50% had chronic pain. Only 10% required further imaging. One who had a CT a month later showed that the cause of the pain was due to diverticulitis. 33% underwent 19 surgical procedures, and they found in these patients had endometriosis, pelvic varices, and adhesions. Their conclusion was that women with pelvic pain and normal pelvic ultrasound will get better with or without surgical intervention, and further imaging is unlikely to yield positive results. A study by Kunin and his group evaluated laparoscopically findings in patients with pelvic pain. In 1,194 patients evaluated, 355 had normal pelvic and normal pelvis. Another 264 had a pelvic inflammatory disease. The others had either an ovarian pathology, pelvic adhesions, or pelvic congestion. Smaller amounts were due to uterine fibroids, endometriosis, uterine displacement, and ectopic pregnancy. Another study evaluated pelvic pain correlated with laparoscopic finding, found that 18% of patients with abnormal pelvic exam had no abnormality at laparoscopic surgery. 63% patients with a normal pelvic exam had abnormal findings at laparoscopic surgery. The causes, the abnormalities seen in a laparoscopy were ovarian abnormalities, pelvic adhesions, pelvic inflammatory disease, and endometrioma. Their conclusion was that there's not always a correlation between the presence of pelvic pain and abnormality of the pelvic organs. The most common causes of pelvic pain due to uterine abnormalities are fibroids, adenomyosis, pelvic inflammatory disease such as endometritis, cervical stenosis or cancer causing distension of the uterine cavity.